Hello, this is Derek Neilson. I'm a medical geneticist from Cincinnati Children's Hospital Medical Center. This talk will be about hypermobile Ehlers-Danlos and the related hypermobile disorders. The objectives of this talk will be to help you recognize clinical phenotypes and problems associated with hypermobile Ehlers-Danlos syndrome and the hypermobile disorders. Additionally, it will help you understand how many patients with EDS you may see in your own practice, and it will help you understand the initial treatment strategies for patients with hypermobile Ehlers-Danlos. When we're looking at hypermobile disorders, we are typically looking at the additional flexibility of joints. Here we can see two patients who can oppose their thumb directly to their wrist, which is a fairly unusual thing for most people to be able to do. And so what we have is Ehlers-Danlos is a group of disorders that have overlapping findings. Loose joints, unusual skin qualities, and easy bruising and bleeding are the findings that most Ehlers-Danlos syndromes have in common. We define hypermobility using a standard set of measurements called the Beighton score. We use hyperextension of the elbows past 10 degrees, hyperextension of the fifth digit, apposition of the thumb to the forearm, and hyperextension of the knee past 10 degrees as standard measurements. These measurements have been performed in different ways. They are not typically done as are shown in this particular diagram. These are shown for illustrative purposes. In scoring the overall Beighton score, we give 1 point for each side for pressing the thumb to the forearm, flexing or extending the fifth digit past 90 degrees, extending the elbow past 10 degrees, and extending the knee past 10 degrees. Additionally, the final point comes from being able to put hands flat on the floor without bending the knees. Each side is scored, so for the arms and knees, there are 8 possible points, and the final point comes from placing the hands flat on the floor. Now, traditionally, we would use a score of more than 5 joints as being defined as hypermobile. However, the criteria for hypermobile Ehlers-Danlos syndrome has undergone a recent revision in its criteria. Initially, the diagnosis of hypermobile Ehlers-Danlos syndrome did not depend on any kinds of problems. In fact, what we would look for is more than 5 affected joints and the absence of other findings that would indicate classic Ehlers-Danlos or other kinds of Ehlers-Danlos subtypes. Now we are looking at this disorder as having some sort of clinical relevance, and the Beighton score has also been adjusted for age and developmental status. So for children who are prepubertal, a Beighton score must now be greater than or equal to 6. Whereas children who have gone through puberty are still at the same criteria of 5. If patients are greater than 50 years old, a score of 4 or more is considered acceptable. However, the diagnosis no longer rests solely on the Beighton score, but it requires clinically relevant findings. And these clinically relevant findings have been divided into 3 different categories. 1, there must be systemic findings of a connective tissue disorder. 2, there must be a family history. Or 3, there must be some form of joint dysfunction. The systemic findings include unusually soft or velvety skin, mild skin hyperextensibility, unexplained stria distensae, bilateral piezogenic papules, multiple abdominal hernias, atrophic scarring, prolapse of the pelvic floor, meaning rectal or uterine prolapse, and this is in patients who have not undergone a pregnancy, so in other words, prepubertal children of both sexes or nulliparous women. And then other findings including arachnodactyly, dental crowding and narrow palate, mitral valve prolapse, and aortic root dilatation. All of those last 4 findings are more commonly seen in Marfan syndrome, and so we must take care not to mistake these 2 conditions. For family history, there must be an affected first-degree relative, and that relative must have been identified and diagnosed independently. It does not count to have one patient with systemic findings and another patient with joint dysfunction and to place them together and call that the family history. One person must have both systemic findings and joint dysfunction to count as that affected first-degree relative. The third category is joint dysfunction, which includes chronic widespread pain of more than 3 months, recurrent joint dislocations or instability without antecedent trauma, and daily musculoskeletal pain in 2 or more limbs for more than 3 months. Any one of these 3 possibilities would count to fulfill that third category. Finally, the additional category is that there must be an absence of confounding disorders. So, for example, if we have a condition in which there is chronic widespread pain, and that condition normally produces chronic widespread pain, then that diagnosis will not allow the use of chronic widespread pain to fulfill this third category. For example, psoriatic arthritis can cause chronic widespread pain, or daily musculoskeletal pain. That will not be helpful for this particular diagnosis, and we would instead be looking for recurrent joint dislocations or instability. Similarly, we cannot count disorders in which hypotonia is a known and expected complication. For example, in the condition Down syndrome, we frequently see children who have low resting tone, and they often have hypermobile joints. This child does not have both Down syndrome and Ehlers-Danlos syndrome. They just have Down syndrome, and the hypermobility is a consequence of the low tone. So the absence of confounding disorders is to help separate out those conditions in which hypermobility may be part of a separate condition. Now, along with the new diagnostic criteria for hypermobile Ehlers-Danlos syndrome came an additional diagnostic entity called the hypermobility spectrum, or also hypermobility spectrum disorders. This is to help us understand that persons who have hypermobility can have problems even if they do not fulfill the strict criteria for hypermobile Ehlers-Danlos syndrome. For example, what we used to look at was the distinction between hypermobile EDS and something called hypermobility syndrome. Hypermobility syndrome was a condition in which there was a lesser threshold for declaring hypermobility, in that there could be 4 affected joints, but it allowed for other kinds of problems to be present to make the diagnosis. So if there were 4 affected joints and pain or other kinds of systemic findings, that could lead to the diagnosis of hypermobility syndrome. However, it was since recognized that hypermobile Ehlers-Danlos syndrome and hypermobility syndrome were really 2 parts of the same diagnostic entity, and it was more or less a matter of time in which a person who was younger, who fulfilled the Ehlers-Danlos criteria, would actually fulfill the hypermobility syndrome criteria as they became older. So now the new hypermobile EDS criteria incorporate that same hypermobility syndrome criteria within it. But that also led to the problem that there are other people who have hypermobility, and they may or may not actually experience symptoms. And what we see is this range of patients who have mild or no problems, all the way up to people who are having very severe problems. Not everyone on that diagnostic spectrum will meet the full diagnosis of hypermobile EDS. And so this allows for some additional room to place a person into this whole category of disorders, even if they don't make the full diagnosis of hypermobile EDS. And this is an important distinction, because what we see is that this disorder changes over time. In childhood, most of our patients have a very mild presentation. they don't fulfill the hypermobile EDS criteria very well because they often don't have the systemic findings. For example, if we're looking for 2 atrophic scars, a patient has had to have had 2 injuries or 2 surgeries which have led to scars. And many of the children that we see do not have that. And so what we often see in our children is that they are mild in their symptoms and they're often very flexible. And we often see a 1-to-1 ratio of females to males. In our clinical population, we often see in the teenagers that males have a tendency to drop out, and they often improve with their symptoms, and in some of them we've even seen their flexibility decrease over time. In contrast, with females, we often see an acceleration of their symptoms, and their flexibility is either retained and sometimes increased. This timing often seems to coincide with menarche. And at that point, in our own particular clinic, what we're seeing is about a 5-to-1 ratio of affected females to males. In adults, what we can see is that flexibility has a tendency to decline, and that has been represented in the new hypermobile EDS criteria, in that if you're over 50, you can have a Beighton score of 4 and still meet the hypermobility criteria. But in some of our adults over 50 and even 40 and sometimes even 30, they have less affected joints than that. Yet the flexibility tends to decline depending on how much activity is going on and how much additional muscle stiffness may have come in from the pain that they may be experiencing. So we do see this change in the amount of flexibility our patients experience, and that is where some of the wiggle room of that hypermobility spectrum disorder is needed. It helps us to allow for the fact that some of the children really look quite mild, but they still may be at risk of developing hypermobile EDS and haven't manifested those findings as yet. In the adults, what we also see is further dropout of affected males, such that there's usually a 9-to-1 ratio in most studies that are performed on EDS. To get a better idea of this transition, we looked at females with hypermobile EDS, aged 21 and younger, and we picked out 42 and looked at when did they first have menarche, when did they have symptoms, and when did they first start getting dizziness with standing. In our patient population, we found that menarche happened at ages averaging 11.7 years. Symptoms occurred at about 11 years, and most typically this was pain or some sort of joint dysfunction, but it could also be orthostatic intolerance. The orthostatic intolerance had an average of about 11.9, and all of these were overlapping between 1 to 3 years. So this time period seems to be a critical inflection point in the development of the disorder. What we think this may relate to is the onset of hormonal cycling in females, although we cannot discount the fact that females also go through the growth spurt at about the same time. When we ask the question, how common is this condition, estimates have varied widely. Previously, and this was back in 2010, the medical resource guide from the Ehlers-Danlos National Foundation was quoting between a 1 in 10,000 to 1 in 15,000 prevalence. However, more recent estimates have put it closer to 0.5 to 2% of the population. And so with such a wide discrepancy, we have to ask, which is it? With such a wide discrepancy in numbers, we looked at our own data within the Connective Tissue Clinic at Cincinnati Children's and evaluated a period of 2.5 years in which there were 2,218 new patient visits, including adults, 95% of whom had been diagnosed with hypermobile EDS. However, that was using the older criteria, not the newer criteria, which is stricter, so we will expect that this number will drop accordingly. However, if we look at those numbers of roughly 2,000 patients, this would suggest that we had seen 7 to 10% of the entire United States hypermobile EDS population. Question is, had we seen that much? And the answer is quite clearly no. The majority of our patients were local. 58% of those referrals came from within 30 miles, and 78% came from within 100 miles. When we look at some of the counties in which there were more common sources of referral, what we found is that those counties represented about, our patient referrals were about 2.2% of that total county population, which gives us a number of about 1 in 500 patients referred to us were suspected as having hypermobile EDS or a hypermobile disorder. Now, what we know from those counties is that we still haven't seen all the patients from that area. It's clearly not a saturated catchment. So what we would expect is that the numbers of about 0.5 to 2% of the population are probably closer to the mark. However, as I mentioned before, this number will change a little bit based on the new criteria. So the next question becomes, what do we actually see our patients for? Or what are the most common presenting problems? And the way I break this down is that there are about 8 common problems in hypermobile Ehlers-Danlos. Now, for a condition in which the joints tend to be loose, joint dislocations would be fairly obvious. And we also can see chronic pain resulting from that. But what we also see are problems like temporomandibular joint dysfunction, autonomic dysfunction, including pre-syncope, the feeling of being about to faint, or postural orthostatic tachycardia, which is when patients stand up, they begin to black out, and then they have a racing heartbeat and other kinds of symptoms. Gastrointestinal dysfunction, such as irritable bowel syndrome, is quite common. We also see chronic headaches, which can be both tension type and migraines. Patients frequently have bruising and bleeding, and while this is usually not problematic, it is problematic when our patients research it on the internet and find out that a common cause of bruising is cancer. And so we often provide guidance on that, not so much because we're worried about it, but just to make sure that our patients don't find alarming and distressing information. Because many of our patients have anxiety and panic disorders. And many of our patients also have sleeping difficulties, which lead to chronic fatigue. Now, when you look at this particular list, it would be daunting for any physician to come across. It's one thing to say you've got headaches, and it's one thing to say you've got anxiety or sleeping problems, but all of these together is a huge list. But that's what most of our patients are coming in with. And while you could say, yes, I get how joint dislocations could occur because you have a connective tissue disorder, it becomes much more confusing to say, why do you have anxiety and panic due to your connective tissue disorder? Where is the connective tissue in the brain? And the answer there is, we don't think that's what it's all about. Instead, if you ask the question, how could connective tissue lead to all these problems, it actually breaks out into about 3 different issues. One is that there's a musculoskeletal problem. That leads to joint instability and pain. But more subtly, and what's not often recognized, is that it also leads to a proprioceptive defect. 2, there is a problem with the gastrointestinal system, and this is most frequently seen in the childhood years with poor motility and constipation, but more complicated disorders can happen with time, and there is some consideration as to whether there might be altered permeability of the gut wall and other kinds of problems. However, these are not well detailed. I will not go much further than that into the gastrointestinal system because it's still one area that we do not understand very well. And then finally, there is a problem with the autonomic nervous system. And this is manifest and most recognizable by the finding or symptom of dizziness with standing. And dizziness does not mean vertigo in this case, but rather more the lightheadedness or the sensation of blacking out. And what we find is when patients begin to have this kind of symptom, we begin to see another problem in that there is an imbalance of the autonomic nervous system. And that imbalance causes or exacerbates the majority of other symptoms that our patients complain about. The easiest place to start in deciphering this condition is with the problem of joint instability. Joint instability often occurs quite young, and where we can see it initially is in the mechanics of the leg. That's actually the most easily demonstrated problem to a patient. And what we see in the panel to the left is that there is a pressure plate distribution of weight on a foot. However, what this problem leads to is a situation of collapse in which the knee moves in a medial direction. This can put strain on the inner portion of the lower leg, but what we also see is that when the body tries to recover, it will use the lateral adductor muscles to try and pull the leg outward. And what we will see is a stress pattern develops in which pain can be felt on the outside aspect of the leg as well as the medial aspect of the leg. And usually this occurs at the end of the long day where a patient has been particularly active. This particular pattern of injury is frequently referred to as growing pains. But when we view it in the context of a flexible flat foot and abnormal joint movement, it is really a mechanical issue and has nothing to do with growing. The fact that it is called growing pains often has to do with the fact that children undergoing growth spurts often have a sudden alteration of the connective tissue, which can lead to such a pattern. While most of us don't worry too much about growing pains in the grand scheme of things, it is much more of a problem when that growing pains becomes more widespread. And so what we see in our teenagers and adults, this pattern becomes spread to the neck, trunk, hips, and legs. And so what seemed to be sort of a benign, self-limited problem is now suddenly experienced as overall body pain. Now, the majority of this pain is really coming from the muscles, tendons, ligaments, and the attachment sites. And true arthritis is very rare at the beginning. So many of our patients will come in having had multiple x-rays, and it is understandable that we usually do not find anything on them because most of this pain is coming from the soft tissue. While it is understandable that patients who have hypermobile joints can experience additional forces on their muscles, leading to pain, what is less recognized is that patients with hypermobile EDS also have problems with proprioception. And there have been a number of different studies, and this has been summarized through a meta-analysis, and what it found is that patients have poorer lower limb joint positional sense. They can have increased threshold of detection to movement, so if a light pressure is placed against them, they will not be able to tell that they are now being displaced from their position versus a person with good proprioception. And if they have their hands placed into a black box and their finger is lifted upward or downward, they are not as able to understand which direction their finger moved. Additionally, what has been found is that the static postural control is impaired, so that patients have more postural sway, and there is more concentration required to stabilize their body than people with proprioception that is intact. So what we can see is that we have a situation where the mechanics of the system are impaired, but also the feedback going to the brain as to how the body is moving is impaired, and these two systems play off of each other to produce more extremes in pain. So what we see in our patients is that there is a proprioceptive defect, but the question is, why should that even be there? Well, if we think about proprioception, it is a sensory mechanism based on mechanoreceptors. For example, in the muscle spindle, the nerve changes its firing rate as its afferent nerve endings are stretched. Stretch and recoil are both connective tissue properties. So if the connective tissue is not functioning properly, if it doesn't have good recoil properties, or if it stretches farther than it should, that nerve signal may be altered. And what has been determined from the proprioceptive defect in our patients is that it is the afferent signal, the signal coming from the sensor to the brain, that is deficient. Therefore, we think it is the connective tissue properties affecting the mechanoreceptors, which is underlying this proprioceptive defect. To put this into perspective, this is a 5-year-old who has been diagnosed as having hypermobility, and he's attempting to stand on one leg. He should be able to do this for approximately 7 seconds, and he cannot. This brings out 2 points. One is that there is an impairment of proprioception, but also our main therapy is to perform physical therapy. This child was given home exercises, and he was then performing them on a near daily basis for approximately 6 months. 6 months later, he can hold his balance much more steadily for a much longer period of time. So not only do we see an underlying defect, it is a defect that is correctable. Overall, therefore, the therapy for patients with musculoskeletal problems is to get them into physical therapy. We work on a couple of different processes. One is alignment, and this is to deal with the flexible flat foot. So what our goal is to try and stabilize that foot collapse so that we can reduce the medial motion of the knee and reduce the overall stress on that system. However, for the back and shoulders and neck, what we have to address is more core stabilization, and this not only deals with the musculature, but also can address the proprioception. Overall, the process of improving joint stability occurs through strengthening the muscles around the joint. What we hope to do is by providing better muscle tone is to provide more passive control of that joint without further intervention. Surgery for our patients is really a mechanism or a choice of last resort, and what we would prefer to do is strengthen by musculature and muscle activity only. Some patients will turn toward bracing or other kinds of options, and that may give us short-term results, but what we prefer is to have the patients controlling the joints without further intervention. Finally, we also have to work on our patients with aerobic conditioning, but that is for a slightly different reason. One of the most common sources of resistance in our patients is that they have said, I've done physical therapy, that didn't work for me. And the problem here is that physical therapy for Ehlers-Danlos really requires providers who have some degree of experience. And what we've heard is that inexperienced providers will push patients too hard, and that will result in pain, and the patient refuses to go back. Alternatively, some of our providers don't know how to push hard enough, and so they are not actually progressing our patients up to the levels that they need to be. Some may adopt an overly aggressive timeline. It is common for our patients to require months worth of physical therapy, and some may be in it for 6 months to a year, and some have chosen to continue on an intermittent basis for even longer than that. And so the traditional 3 times a week for 6 weeks really does not work well for our patients, because we are looking for a more gradual long-term improvement. And the other problem with physical therapists that are not very familiar with this is that they will focus on the wrong goals. And this is one of those confusing pieces, because our patients may go in to say, I have knee pain or ankle pain, or it's my hip that's bothering me. And so the provider will address that specific joint, but not recognize that the whole system is unstable, and we have to address that entire system with core strengthening and proprioceptive techniques. This is a picture of one of our physical therapy programs that is run through Cincinnati Children's. This is our intensive program, which is a 2-week program, which is used to accelerate the therapy progress for some of our patients who are struggling with the more traditional course. And I have the left knee of one of the participants circled to help remind us that we can see our patients going in for one problem and then find out that they are working on anything but that knee at that time. So here they are working with exercise balls, which would be engaging some of the core muscles as well as the arms, but not the knee. Some of the comments of this, of course, are "you will feel so strong." Patients gain more strength, gain more hope. All of those were feedback coming from that particular program. So what we see is physical therapy is a very helpful therapy for our patients, but we have to have the right kind of perspective in how it is achieved. Moving on, the other main problem area for our patients is the autonomic system. The earlier study from 2003 showed that autonomic dysfunction occurs commonly in patients with, and it was here defined as joint hypermobility syndrome. And they looked at 27 patients with hypermobility syndrome versus 21 controls. Over 90% of those patients were female, average age of about 32 years, and 70% of those patients had orthostatic intolerance, meaning when they stood up, they could not maintain adequate perfusion to the brain and would have some kind of symptomatology related to blacking or passing out. This was compared to 10% of that symptom being present in the controls. And this helps us remind us of how blood pressure control actually works, is that when blood pressure drops, sensors in the carotid sinus as well as in the aortic arch, those baroreceptors, will signal the brain as to fluctuations in blood pressure. That signal going to the brain will send out signals throughout the sympathetic chain, which help constrict the blood vessels and activate the heart through its contractility. But that constriction of the blood vessels will help redirect blood flow back toward the brain. What the symptoms of these patients are showing is that that system is not working very well in some way. Now, the pathogenesis of this problem was initially proposed as having to do with something with venous pooling. And the thought there was that excessive vessel compliance would allow all the blood to fill in the veins and it would not be returned. And certainly there is a half-liter shift in fluid volume when going from sitting to standing. However, research on conditions like postural orthostatic tachycardia syndrome, which is one subtype of orthostatic intolerance, has shown that patients with POTS often have low fluid volume, but they also can have elevated angiotensin II and an insufficient aldosterone response. And so while venous pooling can certainly play into this problem, there also seems to be indicators suggesting a lack of a compensatory response to changes in blood pressure. A more recent study in 2014 looked at patients identified as having Ehlers-Danlos hypermobile type. So this is the older definition. And what they found was that there were similar results. They had 74% of their patients having symptoms. And in trying to pick apart this problem even further, they demonstrated that there was a decreased central responsiveness to sudden shifts in blood pressure. In other words, the central control of that system was not being adequately activated. Additionally, there was increased peripheral sympathetic activation at rest, meaning that the sympathetic nervous system was working or had been sensitized. And these findings correlated to semi-quantitative measures of tissue laxity, but the confounder in this study, of course, as with most studies for Ehlers-Danlos, is that there were medication effects as well. So what we understand from this study on autonomic dysfunction is that there's decreased central responsiveness and increased peripheral sympathetic activation. And one of the structures that we have to look at in interpreting this data is the baroreceptor. And what we know about the baroreflex, which is that reflex that protects blood flow to the brain when you're standing, is that this whole system is very similar in its construction to proprioception. In this case, instead of the muscle stretching, what we're seeing is that as blood pressure changes, it deforms the arterial wall. And that arterial wall deformation will then stimulate that mechanoreceptor, which is the baroreceptor, and that changes the baroreceptor firing rate. That is the model of how this system works, and we might expect that, similar to proprioception, changes in the stretch and recoil properties of either the arterial wall or of the baroreceptor itself could change the way it functions. Now, studies to date have had difficulty pulling this out, so it remains a model, but nonetheless, this model seems to fit our patients. And the way we can think about this is that we know that when the baroreflex is dysfunctional, it leads to increased peripheral sympathetic activation. The sensitivity of the system goes up. And this has actually come from a number of different studies on baroreceptor dysfunction. And when we look at our patients, they have increased sympathetic activity, meaning they have an altered fight or flight response. Now, the baroreceptor system works on the chemical norepinephrine. But the hypothesis here is that if this system is not working correctly, then the system will actually engage the sympathetic fight or flight response to overcome the deficiency of the norepinephrine system. And when that fight or flight system kicks in, it is using the adrenal gland derived adrenaline or epinephrine, and when that is released into the bloodstream, patients will experience racing heartbeat, anxiety and panic, suppression of the intestinal system, and it will create a sense of alertness, which, if this engages while a patient is trying to sleep, will lead to sleep dysfunction. So what we see is that the majority of the non-joint related symptoms really seem to come about from overactivation of that sympathetic stress response or that adrenaline response. Treatment of autonomic dysfunction in the past has typically relied on hydration, additional salt, and medications. The fluid target for patients with hypermobile EDS is about 50% more than is typically recommended. 64 ounces of fluid per day is what is recommended for most adults. Our patients need more, about 100 ounces. And the reason for this is in part due to the loss of the central responsiveness. That whole system can help improve the renal resorption of fluid, and so our patients tend to make more urine than everyone else. Because of that, they become dehydrated more easily, and they have a higher replacement goal. For the same reason, patients have to have additional salt because the kidney mechanisms for salt retention are also less than they should be. So our patients tend to lose a lot of water and a lot of salt. Another problem with this whole system is that despite the fact that our patients are typically dehydrated, they will tell you unequivocally they are not thirsty. They do not feel the need to drink. This is another piece that helps support the idea that the baroreceptor is dysfunctional, because one of the roles of the baroreceptor is also to communicate to the brain the volume status, and its primary output is to adjust the level of thirst. When this is not working, our patients are simply not thirsty. So what we have to do is get our patients drinking a lot more, getting a lot more salt, but it can be a disruptive process because our patients may have such increase in urination that it is becoming disruptive to school, work, or sleep. Medications have been used to help compensate for some of the deficiencies. So Florinef is used for patients that are having problems with the renal resorption mechanisms. Midodrine is used to help increase peripheral vascular resistance, which can help return blood to the brain. And beta blockers are used to decrease that excessive sympathetic response. This can be especially helpful in patients who develop such tachycardia that they drop their filling pressures, making ineffective heartbeats. So some patients have such a degree that the tachycardia will actually cause additional fainting episodes. However, while all of these have been traditionally used in the past, we have become much more interested in a more recent development, which is the use of aerobic exercise. And what we have turned to is a protocol that was developed for patients that have postural orthostatic tachycardia syndrome. And what the study showed is that aerobic exercise is as effective as beta blockers in controlling symptoms of orthostatic intolerance. Not only that, patients undergoing an aerobic exercise program of 5 days a week, 30 minutes per day, with their heart rate at 80% of its maximum, can have increased blood volume, increased or improved indicators of baroreceptor sensitivity, and it can also improve sleep, anxiety, irritable bowel symptoms, and pain. And those have all come from different studies, but the study that evaluated the effect on patients with POTS did demonstrate that the patients who were exercising had improved quality of life, and patients on the beta blockers did not. Now, if you simply say to a patient, what really helps is exercise, you're going to get a dirty look. Because most patients with hypermobile Ehlers-Danlos will tell you that they have chronic fatigue, pain, and dizziness with standing. And that dizziness with standing translates into dizziness with exercise. Exercise is not comfortable for them. And so how that exercise is achieved is very important. And so the protocol that was used for treatment of POTS used seated exercises or pool-based exercises to overcome the gravitational stress on blood pressure that comes about from standing. So the seated exercises were exercises like recumbent bicycle or rowing machine, and pool-based exercises included swimming or kickboarding. However, we've also seen patients improve by walking or running in the pool, water aerobics, and other kinds of activities. And the pool is particularly nice on patients with hypermobile EDS because it reduces the strain on the joints. But additionally, the water pressure can provide additional peripheral vascular resistance, and that improves blood pressure stability. So what we see is that our patients do not get dizzy with standing in the same way that they tend to get that while out of the pool. And overall, if the problem is that the sympathetic nervous system is overly sensitive, exercise helps activate that system and it will desensitize it. The trick with that, though, is when patients initially start that exercise program, they will activate that sympathetic system and it will be too sensitive. And that combination will feel bad. And so what we have to help our patients understand is if they try to do regular exercise like they're used to, it's not going to work like they think. Not only do they have to change the type of exercises that they do, but they have to expect that starting that program will be a rough go. It will take time for that system to adapt. The results from that initial study had demonstrated that it can take up to a month for patients to start to feel even and not feel bad from their exercise programs. We have in our own patients seen variable results. Some of that can go quicker, and in some patients it takes longer. But that is a very critical piece that needs to be communicated to patients. Otherwise, they're likely to start the program and promptly quit. So when we see a patient who has hypermobility, we have to decide what are we going to do with this patient. In a child who has hypermobility, we have to consider the diagnosis of hypermobile Ehlers-Danlos, although we may not actually give that diagnosis right away. However, if there are physical problems like pain or proprioceptive defects, then we would recommend getting that patient into physical therapy. And we may even consider putting that child into physical therapy if there is a family history of patients experiencing pain as they go through puberty. Additionally, what we want to do is help our patients establish the kinds of habits that will serve them well if they were to actually develop those symptoms later on. So we want our patients to be active, but we don't necessarily want them to participate in high-impact sports. So we like them to get into sports like swimming or rowing or cycling, not necessarily football or gymnastics. Additionally, because the habit of fluid intake is not well ingrained into many of our patients, we really want to try and catch them at an earlier age and make fluid intake a habit, so that all we have to do, should they have more problems when they hit the teenage years, is adjust that habit rather than to start it as a brand new. It often is a question as to what do we do with these patients? Do I tell them to take it easy, or do I tell them to do more? And what we have found is that it really is a situation where it is more helpful to tell patients to continue to push forward and be active, because if we tell them to relax and sit back, we tend to see more problems coming out. For patients who are older, we may have to do more referrals. And so physical therapy for proprioceptive training and joint protection we've already talked about. But we've also seen that for patients who are struggling with pain and changes to their life because of pain, cognitive behavioral therapy can be very helpful in helping patients find new and different ways to handle pain when it occurs, rather than the typical, which is many of our patients become avoidant of situations that produce pain, and that can lead to a restriction of their way they lead their lives. And so in the more extreme examples, we see our patients becoming more restricted to the house or even to their room, and become so fearful of pain or other kinds of symptoms that they do not venture further out. Cognitive therapy or cognitive behavioral therapy is one way to help break through some of those barriers. In patients who are experiencing more pain, we start with the easier medications like nonsteroidals, and if we get to higher kinds of problems than that, we may turn to pain management. And the pain management that we are looking for is more along the lines of what is used for fibromyalgia. It has been recently demonstrated that the central pain sensitivity that occurs with fibromyalgia also occurs in patients with hypermobile Ehlers-Danlos, and so those medications are very appropriate. We do try to stay away from narcotics and muscle relaxers whenever possible, because those classes of medications can lead to more joint instability, which can further exacerbate their underlying pain. Some of our patients may benefit from seeing a headache specialist or a headache clinic, and I put syncope clinic in parentheses because while we used to be more aggressive in terms of sending our patients to specialists, what we found is that actually the strict attention to fluid intake, salt intake, and consistent exercise has actually yielded better results than many of the medications that have been used. So we really start with that paradigm first before turning to further intervention. And one thing that should be considered for patients who are experiencing dizziness with standing is an EKG. If that is normal with no signs of arrhythmia, then we'd really pursue that exercise program. And finally, in terms of orthopedics and other surgical referrals, we usually only turn to that if we are dealing with a situation of unremitting pain or joint dysfunction where physical therapy is not making any gains. To summarize, hypermobile Ehlers-Danlos and its related hypermobile disorders these are common conditions, and these can produce a wide degree of systemic complications. However, if we understand these complications as a series of feedback loops that are impaired, we can get a better understanding of how this system is actually functioning. To address those feedback loops, what we have to achieve is physical strengthening and aerobic conditioning. And this has been able to provide excellent results for our patients. However, without the ability to effectively communicate these concepts to patients, the patient will likely reject attempts to put them into physical therapy or to have them exercise. If they can understand how these models work, however, we have seen patients readily adopt them and make very positive strides. It is that insight that I hope that you will take away from this lecture today. Thank you very much.